Good afternoon. From all of us at the institute level, Honorable Dean Madam has already conveyed her messages. So we would like you to start as early as possible. So on behalf of me and my colleague Dr. Garkal, we extend a lot many best wishes. So please go ahead. Thank you so much. All the best, madam.
Thank you so much, Dean ma'am, and all the deputy deans. Now we will start with our webinar, No Dementia and No Alzheimer's. I would like to introduce the first speaker, Dr. Ujjula Daifale ma'am. She is a renowned plastic surgeon and also the Honorable Secretary of the IMA Association Aurangabad. I would like to welcome her, and she will be giving a review of the Alzheimer's disease.
A very good afternoon, all of you. Indian Medical Association Aurangabad branch, in association with Government Medical College and Hospital Aurangabad, on the occasion of World Alzheimer's Day. It's always celebrated on 21st of September. And this time theme is Dementia, no Dementia, no Alzheimer's. And organizers of this webinar are Dr. Varsha Rote Madam, Dr. Srinivas Gadappa Sir, Dr. Shiraz Beg Sir, Dr. Kashinath Garkal Sir, and IMA President Dr. Sachin Fadnis, and Professor and Head of Geriatric Department Mangala Bodkar Madam, and Dr. Prasad Deshpande, who is a Professor and Head of Psychiatry Department, Government Medical College, and Dr. Shailaja Rao, and coordinator of this CME, Dr. Ashish. And I welcome all of you. And I think this is a need of society nowadays to work on Alzheimer's. Basically, this is not being a plastic surgeon. I will not be able to talk too much about the Alzheimer, but dementia and Alzheimer's are very challenging diseases to manage. Patients have loss of memory, mood swings, irritability, and neglect self-care. They require assistance for the activities of daily living, but providing this assistance is also very difficult. They often forget food and medicines, may demand these repeatedly. Many a time they are in bad mood and one has to calm them down actively. They totally neglect self-care, so we may have to provide even oral and back care of these Alzheimer patients. And not only the mental but nutritional support is also required for all these Alzheimer patients. We have to deal with them with a lot of patience, sympathy, and empathy. I think, Ashish, now I will hand over this to you again. Thank you very much for the opportunity, and best of luck for the webinar. Thank you.
Thank you so much, ma'am, for that overview. I would like to invite the next speaker, Dr. Shailaja Rao, ma'am. She is the Associate Professor in the Department of Geriatrics, GMC Aurangabad. Madam will be talking about the introduction and the types of dementia.
A very warm welcome to everyone in this dementia webinar. I'll be speaking on the introduction and types of dementia. So basically, to start with the functional anatomy, we can all recall from our MBBS days the language network, most importantly formed by frontal lobe, temporal lobe, and parietal lobe, with the motor area in frontal and Wernicke's area in the temporal lobes. Similarly, the memory circuit, we all know the amygdala and hippocampus. They are the integral part of memory circuit which make and add the memories, and it is stored in the cerebral cortex. And cerebellum is related with the memories related to complex motor work, execution of the memory. So what is dementia? Basically, dementia is progressive decline in the cognitive functions. When we talk of dementia, more often than not, only the memory part is being stressed. But dementia is not only decline in memory, but it is abnormal perception, difficulty in reasoning, abnormal thinking, poor judgment, and various problems of languages. So all these clinical features will be discussed in detail by Deshpande sir. So I'll be just enumerating the changes. These are the different changes that we get to see in patients of dementia. The language abnormality, mostly they are related with trouble speaking clearly. Most of the time they are not understand what we are speaking, trouble in writing properly, trouble in understanding the written words, and sometimes naming the object. They know the object all their life, but they are not able to name the object. The second important aspect which I would like to discuss is visuospatial skill impaired. This is related with a person's position in the environment, the position of body in relation with the environment. And this visuospatial skill impairment mostly leads to forgetting the commonly known paths, forgetting the routes, and wandering away. So NIA Association, that is National Institute of Aging and Alzheimer's Association, they have given this clinical diagnostic criteria for dementia. And we label a patient as having cognitive or behavioral symptoms when it is interfering with the ability to function at work or usual daily activities. So we call it dementia when it starts interfering with the daily activities. It represents a decline from the previous level of functioning and performing. So most often the caregivers or the relatives will tell you that person was able to perform various functions previously, and now they are not being able to do so. And most important thing, all these symptoms are not explained by delirium. Delirium is acute onset of confusional state. So this should, before labeling a person as dementia, we must exclude delirium and other major psychiatric illnesses. Many a times persons come to our OPD and they say, I have this memory impairment, is it dementia? So there is a clear-cut demarcation between benign forgetful of normal aging versus dementia. So what are the important factors? Usually in normal aging, the person may make a bad decision occasionally. But in dementia, they are doing that repeatedly, so much so that it is interfering with their daily life. Similarly, missing a monthly payment as opposed to inability to manage the budget. Previously, they were able to manage the finances. Now they are not able to go to the grocery shop and take the money or take the change. So that is important. Similarly, forgetting which day it is, as opposed to dementia where they just lose the track of seasons. Sometimes forgetting the word is normal, but in dementia, they are not able to strike a conversation at all. That means it is an extreme level of benign forgetfulness, and not only memory part is impaired, but the language, the execution of motor function, and the functional impairment. Now there is a concept which is called pre-dementia or mild cognitive impairment. Just like pre-diabetes, there is pre-dementia. As we know, pre-diabetes is a state where we don't need the drugs and you just need to observe the patient. Similarly, in pre-dementia, you don't treat the patient, but it is a stage. Why it is important to diagnose pre-dementia? Because from here, the person may progress to dementia or it may remain static. So what is pre-dementia? The patient or the relatives or the clinician, they will tell that the patient has a concern regarding change in cognition, decline in cognition, then on examination, there will be evidence of lower performance in one or more cognitive domains. That may be memory, executive function, attention, language, or just as we discussed, visuospatial skills. The person maintains preserved independence. This is very important, as opposed to dementia, where person is dependent on others. The day-to-day life is not affected in pre-dementia or mild cognitive impairment. So it is very important to check for this pre-dementia and pick up it in early stage so that you can intervene, you can start behavioral therapy, you can start other treatment at the earlier stage. Okay. So if you look at the difference between normal aging, minimal cognitive impairment and dementia, there is cognitive decline in cases of minimal cognitive impairment as well as dementia, but there is no functional decline in minimal cognitive impairments. So what are the different causes of dementia? The causes of dementia may be reversible or they may be irreversible or progressive. So we, as clinician, we should not miss any opportunity to diagnose the reversible causes of dementia, because that may completely change the life of the elderly. So the reversible important causes include depression, delirium, medication, and nutrition. And the irreversible causes are the progressive disorders, trauma. So when we say depression, it is very important mimic of dementia in elderly individuals, and the treatment may be gratifying. So it is always important to pick up depression. Second is obstructive sleep apnea, which can be diagnosed by sleep studies, and CPAP helps to a great extent. Alcohol-related dementia or Korsakoff psychosis, which is reversible in early stages. So high index of suspicion is needed in all these cases. Then hypo and hyperthyroidism, both may lead to dementia-like features in elderly. TFT is must in dementia workup. Similarly, psychosis associated with myxedema, which is conventionally known as myxedema madness, and it responds well to thyroid hormone replacement. Both hypo and hyperparathyroidism can also produce dementia. Vitamin B1, vitamin B3, and vitamin B12. These deficiencies can lead to dementia. Especially vitamin B12 deficiency is very important in elderly individual. We all know the most important sources of B12, they come from the non-vegetarian food. So the person who is vegetarian, and if they are not taking enough quantity of milk, they are bound to develop B12 deficiency. B12 deficiency is one of the most common nutritional anemia in elderly, and it must always be looked for. Then normal pressure hydrocephalus, VP shunt may be the treating option. Now we come to the main part of dementia, which is progressive dementia. The progressive dementia most common cause is Alzheimer's, which is seen in 50 to 75% of cases, followed by vascular dementia, Lewy body dementia, and frontotemporal dementia. Frontotemporal dementia is most common cause of dementia in persons under 60 years of age. If you look at this picture, the normal versus Alzheimer's brain, then you'll recognize that there is atrophy of cerebral cortex as well as atrophy of hippocampus, which is the main issue with persons with Alzheimer's. Similarly, this is on above there is healthy neuron, and the lower picture is showing neurofibrillary tangles with disintegrated microtubules, which is the main pathologic feature in Alzheimer's disease. The 5 Alzheimer's clinical cues include anomia, apraxia, agnosia, aphasia, and amnesia. If we talk about frontotemporal dementia, in Alzheimer's dementia, mostly the cerebral cortex is involved and the hippocampus, the memory part. While in frontotemporal dementia, it is the frontal lobe and temporal lobe which bear the main insult. So, understandably, if the frontal and temporal lobes are involved, the predominant clinical feature of frontotemporal dementia is language disorder, as opposed to Alzheimer's, where main problem starts with memory. So in frontotemporal dementia, behavioral and language changes, they occur early, and it is the most common cause of early onset dementia. We all know vascular dementia caused by multi-infarcts, multiple strokes. The most common risk factors include diabetes, blood pressure, high cholesterol, peripheral artery disease. Dementia with Lewy body. There is deposition of Lewy bodies in the neurons. It was first described by Friedrich Lewy. The most important thing is dementia with Lewy body. It has some features of Alzheimer's-like disease because of memory deficits. Similarly, it has got some features of Parkinson's disease manifested by bradykinesia, resting tremors, rigidity, and there is associated cognitive decline. The visual hallucinations are an important clinical feature of Lewy body dementia, and which may warrant starting psychotropic drugs. Thank you. Thanks a lot. I hope I have finished in time.
Thank you so much, Rao ma'am, and also for emphasizing to rule out the reversible causes before concluding a progressive dementia. Our next speaker is Dr. Prasad Deshmukh sir. He's a renowned Deshpande sir. Prasad Deshpande sir is a renowned psychiatrist and also a great academician. And he has a 20-year experience in the government service and currently working as a professor and head of psychiatry, GMC Aurangabad. I welcome you, sir, for the talk. Sir will be discussing on the behavioral and psychological symptoms in dementia.
Good afternoon, everybody. I'm grateful to all of you for joining this webinar. Secondly, I thank the organizers and officers of Indian Medical Association Aurangabad chapter and especially Dr. Borkar ma'am for sharing this opportunity of self-expression. I shall be giving an overview on behavioral and psychological symptoms of dementia. In short form, they are known as BPSD. They are also called as neuropsychiatric symptoms. What are these? They are a heterogeneous group of non-cognitive symptoms and behavior occurring in persons with dementia. That is, it is not memory disturbance and it is not intellectual disturbance. It is beyond these two conditions. All what includes abnormal behavior, disruptive behavior, has to be categorized as BPSD. They form a major component of the dementia syndrome, and it is not restricted to Alzheimer's per se. FTD or Lewy body dementia or other subtypes, they all can present with BPSD. They are relevant. Why? Because they strongly correlate with degree of cognitive and functional impairment. How do these conditions show up? Commonest is agitation, aberrant motor activity, anxiety, elation, irritability, depression, apathy, disinhibition, delusions, hallucinations, sleep and appetite changes. Let's look at some of them. Why we need to attend to the BPSD? Because they are associated independently with poor outcomes. Distress amongst the patients, more than that, the caregivers. What the caregivers face, we'll come to know from Borkar ma'am's talk. Long-term hospitalization, misuse of medication, and increased healthcare cost is an issue with people having BPSDs. And they can occur individually or they can occur with psychiatric comorbidity like depression or psychosis. Why do these BPSD emerges? It is not known. Pathogenesis is a complex interplay of biological, psychological, and social factors. There is a role of neurochemical, neuropathological, and genetic factors giving rise to this picture. Often it is understood that the individual is unable to cope up with the stress. Much depends on what? The premorbid personality of the individual, the pattern of thinking, and the pattern of emotional reactivity. All this gets disproportionately out of context once BPSD develops. How to locate these symptoms? It is very essential to be a responsive physician in such a way that patient feels comfortable sharing the experience. We must be non-judgmental, non-critical. We must not think of right and wrong when we are listening to the patient. Just listen. Listen from no filter. Be attentive, be observant, and listen in a good mood. It is also important to understand what the patient is trying to say. For example, patient in Marathi says, "Mala mungya distat." Ata mungya distat can be something a psychophysiological experience. पण केव्हा दिसतात, कुठे दिसतात? The patient explains की भिंतीवरती मुंग्या चालल्यासारख्या दिसतात आणि फरशीवरती मुंग्या चालल्यासारख्या दिसतात. On exploring, this turns out to be a Lewy body dementia. There is a visual hallucination there. So we must not miss the description given by the patient. High degree of clinical expertise is crucial in picking up these conditions and solving these conditions. Subjective experience must be heard attentively and patiently. Do not ignore observations of caregivers, relatives, and the physicians. What to look for? There are these 6 areas where the BPSD will present. One is emotions, second mood, third perception, fourth thought, fifth motor activity, and eventually altered personality traits. Whenever the family members are in distress and the patient says, "I am okay," always suspect there is something wrong in the personality, there is something wrong, could be dementia. What disturbances in emotional experiences to look for? It will not be a classical picture of depression. So don't look for sadness, unhappiness, preoccupation with negative, depressing topics, hopelessness, suicidal ideation, and loss of self-esteem. Because patient does not experience dysphoria. Patient's clinical picture gets masked by the dementia. So these experiences include loss of interest, which was initially pleasurable. I no longer enjoy TV. I no longer enjoy reading the newspaper. That could be the presentation. Somatic concerns. इकडे दुखतं, तिकडे दुखतं, and बेचैन वाटतं, अस्वस्थ वाटतं, कशातच मन रमत नाही, काहीतरी होणार आहे, काय होणार आहे माहित नाही, मृत्यूची भीती आहे का तर तसंही नाही, पण बेचैन वाटतं. That is the experience of the patient. Subjective unpleasant experience of fear can show up as apprehension, tension, or panic. And then there is disordered motivation. We also call this as apathy. No experience of emotion is there. There is diminished goal-directed behavior. Some patients, they develop mania-like picture, elated mood, disproportionate to circumstances, and they have heightened emotional tone and reactivity. Some of them get irritable. Some of them are just uneasy. Some of them have rapid shifts in their emotions. It's also known as affective lability. And it is important to note that hunger, sleep disturbances, and pain, they aggravate these experiences. Now let us come to perceptual and thought disorders. Hallucinations, illusions, and delusions are the words which we have been listening to from our medical graduation days. Just to revise a bit, there is a sensory perceptual experience in absence of real external stimulus in a hallucination. So there is perception happening without any stimulus. Then there are people who experience incorrect perceptual experience in spite of sensory stimulus. We call this illusion. Mistaking a rope for a snake, that is illusion. And when there is a stimulus, when there is correct perception, although the individual cannot draw correct inference, he reaches a false inference, false conclusion about the stimulus and holds on to it. Then we say it is a delusion. Let us see some examples. Perceptual disturbances can include every sensory modality. They may not be easy to differentiate from delusions. Visual hallucinations are the commonest. They come recurrently. They are well-formed images of animals or persons, and the Patient describes this in detail. Just listen to the patient and you'll come to know varied flavor of these perceptual disturbances. Commonest delusional content is persecutory. People coming into home and they are hiding objects or they are stealing objects. In one of the patients, it was very classical. The maid used to come at home and work. The house owner, the lady, who was suffering from dementia, started feeling that she is going to take away her clothes. And her daughter-in-law would explain ki asं काही नाही आहे, असं कोणी करणार नाही, नाही नाही तुला समजत नाही. She is going to do that, and she would insist कि her clothes will be stolen by her. So these are the things which are very common to look for. We often mistaken this as paranoid psychosis. Before diagnosing it as paranoid psychosis, it is important to do a neurological assessment. Second, common conditions like patient says ki जिथे मी राहत आहे ते माझं घरच नाहीये, ते दुसरंच कोणाचं तरी घरी आणून ठेवलंय. Or they may accuse कि तुम लोग मेरे को छोड़ देने वाला है, मेरे को तुम हॉस्पिटल में भेज देने वाला है. Or they may feel that the spouse is unfaithful, or they may feel that there is some discriminatory intent of the person who's coming to meet. So commonest theme is persecution. That we have to suspect whenever we are examining for BPSD in dementia. The motor disturbances could be slowed movement, or they could be increased movement. There could be a slowed speech, or there could be rapid speech. There could be a reduced body tone, or there could be increased movements or reduced movements. So either of it could be a presenting feature. Let's come to agitation. Agitation is inappropriate verbal, vocal, or motor activity. It is not related to needs of the patient. It is not related to confusion the patient experiences. It is something which is not explained. This could be physically or verbally aggressive and non-aggressive conduct. How does it show up? Agitation shows up as wandering away from home, repetitive purposeless behavior, and doing socially inappropriate activities like getting disinhibited, disregarding the norms, and having an unrestrained expression of one's own feelings. Also, we have to look for circadian rhythm changes commonly seen in sleep, that is pattern changes. It could be hypersomnia, could be insomnia, could be reversal of the sleep-wake cycle, it could be fragmented sleep, it could be daytime napping, there could be nighttime awakenings, and overall there is a decreased quality of sleep. Now, before we say that this is BPSD, please establish that the clinical picture is not due to pain, it is not due to a medical illness that is got missed, it is not due to fatigue, it is not due to depression, it is not due to loneliness, it is not due to an understimulated neuron, it is not due to overstimulated neuron or stressors. Once all these conditions are ruled out, then you can say that there could be BPSD. Now let us come to how to handle these situations. First and the last, I would say, is non-pharmacological approach. What non-pharmacological approach? Patient feels persecuted. Okay, fine. Don't teach him that this is unreal. You just validate the patient. की ठीक आहे, आपण सांगू तिला कपडे नको चोरून देऊ किंवा चोरलेले कपडे परत आणून दे. That is how we can tell the patient and soothe the patient. Then we can do some behavioral management, do some soft exercises, do some light therapy, aromatherapy, massage, or music. These are all simple interventions where you are giving a human connect to the patient instead of disregarding and disowning the patient. Preferably avoidable pharmacological management. Why to avoid them? Because there is more of problem rather than benefit. Different drugs that we talk of is antipsychotics, which are typical like haloperidol, atypical like risperidone, olanzapine, quetiapine, antidepressants like escitalopram, citalopram, sertraline, anticonvulsant mood stabilizers, donepezil, galantamine, rivastigmine, benzodiazepines, and memantine. An adventurous physician may feel that I am doing something great by using pharmacological approaches. I am sorry to inform there is more harm than some benefit. If at all you are compelled to use it under the supervision of a neurologist and a psychiatrist. Risk-benefit analysis is most necessary. Use the least harmful medicine for shortest possible period of time in minimum dosing. That is the mantra to be followed. Convincing evidence for antipsychotics, for aggression, for management of behavior disturbances is not available, yet they are used widely. The problems with these drugs include extrapyramidal reactions, sedation, gait disturbances, falls, anticholinergic side effects, cerebrovascular events, and even increased mortality. Old person started on antipsychotics, sudden death, have to question that these drugs have been used. To summarize, BPSD develop in 90% above cases of sufferers of dementia. They cause suffering to the caregivers also. Clinical presentation can be attended. It is all about good history taking from the patient and the caregivers. Be non-judgmental, empathic, and compassionate in understanding the disruptive behavior. First, rule out other causes. Second, prefer non-pharmacological measures. Wherever at most necessary, use very minimal doses of drugs for very short period to reduce the suffering. And finally, I don't know whether the culture permits or not, I have to say it, prepare the family for dignified passing away of the patient. Enough has been done, adequate care has been taken by the family. Now accept that our person, our loved one may not continue for long. That's it. All this is what I thought I'll share with you all. Thank you.
Thank you so much, sir, for that wonderful and informative talk about the behavioral and the psychological symptoms in dementia. Our next speaker is Dr. Mangala Borkar, ma'am. She is the professor in the Department of Geriatrics, GMC Aurangabad. She was the former professor and head in the Department of Medicine, GMC Aurangabad. She is also the nodal officer for geriatrics in the state of Maharashtra for starting MD geriatrics in all the government medical colleges in the state of Maharashtra. And she is also the first to start an MD geriatrics PG department in the government medical college in the state of Maharashtra. I welcome you, ma'am, for your presentation. And she will be discussing on the role of caregivers in dementia. Over to you, ma'am.
Thank you, Dr. Ashish. Thank you, Dr. Rao and Professor Prasad for your excellent presentations. At the outset, I thank our Dean, Dr. Varsha Rote Kaginalkar, our Deputy Deans, Professor Gadappa, Dr. Beg and Dr. Garkal, and all my colleagues in the GMC Aurangabad, at GMC Aurangabad for their the interest that they show in our academic activities. I am sincerely thankful to IMA President, Dr. Sachin Fadnis, IMA Secretary, Dr. Ujjwala Daifade Madam, and our Treasurer, Dr. Deshmukh, and my friend, Dr. Ujjwala Jhawar, and all the IMA office bearers for having given us this opportunity to collaborate with them and having this activity together. Thank you very much. A very simple type of presentation of mine, and all of you must have taken care of some kind of patients, maybe elderly, maybe children, so you are aware about the responsibilities and the tensions that caregivers can go through. Just a recap, actually, you, Dr. Rao and Professor Deshpande has explained very nicely, so I won't go into the details of dementia, but one important thing is that it's an acquired mental disorder and mostly progressive, though we have to rule out, as Dr. Rao said, the treatable causes. And today we are dealing with Alzheimer's. The main problems with these dementias are that the patients are dependent on others for their day-to-day activities. They need round-the-clock observation and help. And they may be very difficult to control compared to other elderly persons who are bedridden or who are terminally ill. So it can be very taxing and full of tension, as I mentioned earlier. And caregivers always have a vital role at the extremes of life, but especially if the person is demented. Now, as you know, the caregivers, mostly they are informal. Maybe about more than 95, 98%, particularly in the developing countries like ours, are informal, family paid caregivers who are naturally unpaid and who are members of the family related to the person, or maybe sometimes some friends and all may chip in to help, but the regular caregiver is mostly informal. Occasionally there may be formal, who may be trained, or they may just be paid. They may not be trained, but they are paid caregivers. In the family, mostly it's the spouse, the son, the daughter-in-law. In about 24% of cases in our country or in developing countries, maybe a sibling or sometimes other relatives. 80% or more of the caregivers are females, ladies in the house. There are some who are just care providers. They may provide all the logistics, including medical care, and they may supervise, guide, but they don't actually take care of the patient. And they are called care managers. Then the care providers, actual care providers who work with the patient, who take care of the day-to-day activities of the patient, they are likely to get more stress. Now, why do we give? Why do we become caregivers, or why does anybody become a caregiver? There are some positive aspects. Maybe it is love for that person. That person is a loved one. Out of duty, you have to do it. Or it may be a spiritual fulfillment, or you want to repay whatever they have done for you when you were small, when you were young. For example, your parents, whatever they have done for us. So it's love as well as kind of repaying whatever they have done for you, in not in terms of money, but in deeds. Then there are negative reasons also which cause more stress. There is no choice. You have to look after. Then if you don't look after, you feel guilty. So you have to look after. There are social and family pressures. That son is not looking after the parents. The daughter is not taking care of her mother or father. So for that, people look after. And of course, occasionally it may be greed, that you will get something, maybe the estate or the land or the house or the money or the jewelry from that person. So then sometimes they are looked after for those reasons. Well, a case of dementia may be, thankfully, maybe just forgetful and just blank, quiet, a little withdrawn, but absolutely maybe very kind of benign type of a person also. Or it may occur intermittently. So at least such spells are welcome, and particularly to the relatives. The demented patient at the extreme end is blissfully unaware of what problems he is creating or what is happening to him. But it is mainly the relatives and the caregivers who have to go through everything. And therefore, if the patient is just forgetful and sitting quietly, well, that is something which is okay. But the patient may be very violent, and he may be dangerous also to himself as well as to others. The person may be uncooperative and abusive. And in that case, a lot of problems you can see that right from taking care of the day-to-day activities to handling the patient and his relationships with others can be a big problem for the caregiver. The person may be very difficult to control, and it may create great problems again. That relatively benign, not violent, but does what he wants and doesn't do what you want, absolutely, which is logical. So it may be very difficult to control. Another great problem which happens, as Prasad sir said, is that the person may be having tendencies, may just walk out of the house and go somewhere and get lost, may meet an accident, may fall somewhere. So these are again very dangerous things which can happen in dementia. Now, there are many changes that have occurred in the recent years, which you are aware of, that formerly we had a joint family and now we have a nuclear family where mostly everybody is working and out of the house. And traditions, values, priorities, attitudes, everything has changed. People, the sons or the daughters or the other relatives, they migrate out for education, for job. More and more women are working, which is very welcome. But formerly the women who were in the house looking after the demented or any elder patient, they are now very busy most of the day. And the relationships have changed. The siblings or the spouse may be unwilling to look after the demented patient, and therefore the burden may fall on only one person. So that person may resent it. And there are various characteristics of a caregiver: the nature, the attitude, the sense of responsibility, values, the personal life of the person. Then if the caregiving may be forced or imposed, there may be bad relationship with the patient, the time, lot of time may have to be spent in dementia. It may be almost 24 hours looking after the patient, restriction of own activities, social isolation, and the person also may be ill, addict, depressed, poor. So some all the time you cannot keep blaming the caregivers, but there may be various problems. And the caregiver has to look after so many things, right? Day-to-day activities, dressing, medicines, eating, ambulation, moving around, companionship, housework, own housework, communicating, and finances, and of course, controlling the unruly patient. So these are the various things which the caregiver of a demented patient can do. And if it is the spouse, the elderly man is demented and his wife maybe a frail elderly lady who is already ill, you can imagine how difficult it may be for her to manage that particular patient who is her husband, though she wants to do it. Then the effect of caregiving will depend on various things. It will depend on the attitude of the person, the relationship of the person, how much there was love and affection between the person earlier, the traditional values, norms, and the caregiver may adapt. He may take care with love, affection, or at least in an indifferent manner, not let it affect himself much. Or the caregiver mostly will suffer from wear and tear, stress, burnout, resentment, and anger. And this may lead to abuse of the demented person. So it's quite common for demented persons to be mistreated at home as well as in institutions. And imagine it is bad enough to be very old and nobody to take care of you. And if you are abandoned and you are poor, and on top of it, if you are demented, you can imagine the plight. And we all should think over this and try to see what we can do about it. So for the caregiver, it can be that the patient is neglected, or while taking care of the patient, the family is neglected, especially the children. And then often the choice is they triage or they choose the children. And therefore, naturally, you cannot always blame them, but then the elderly demented person can get neglected in the household. And abuse can occur at various levels, particularly if the elderly person is demented and not able to complain, not able to understand what is happening. It is very common for that poor elderly person to get mistreated. There are certain various type of tests which are done. How do you feel as a caregiver? Whether the burden is very severe, whether it is a little more elevated. Sometimes you feel burden, or you rarely or never feel the burden. So there are various tests which are used. And one of these tests is a Harriet burden interview. The caregiver burden, which is assessed by never feel burden, rarely feel, sometimes feel, quite frequently, and nearly always. So accordingly, the marks are given and various questions are asked. Do you feel, for a first question, do you feel that your relative asks for more help than he needs? Do you feel that because of the time you spend with your relative that you don't have enough time for yourself, etc. So 0, 1, 2, 3, 4 is the scale. And accordingly, there are 22 questions, and the interpretation would be if the score is 61 to 88, the burden is severe, and if it is 0 to 21, it is little or no burden. So it is a good validated type of scoring system which is there. Now the burden is definitely there. Now we have to see how to reduce the caregiver burden. That is very important. Now first is how can the family help? It is mainly the family who can help. First, share the caregiving. Mostly it is dumped on one person. So that should not be done. It should be shared, if not equally, at least reasonably it should be shared by the other members of the family, provided they are there. Sometimes only an old couple is living and there may be problems. Share other work also, not only the work of caregiving, but other, say, household work or shopping or whatever is there. So you share the other work. Appreciate the caregiver. If you cannot appreciate, at least do not blame or scold or criticize or backbite about the caregiver. Don't keep on criticizing, because that is very demoralizing and demotivating for the caregiver. And you give some space, personal space. The person should not have to leave her or his job. Some family life is there, personal life is there, social life is there. So some compromise has to be done, some adjustment has to be done, but a little bit at least give some respite to the caregiver. That is very important, and this only the family can do. Then kindness, respect, and dignity to the demented patient, very important, and also to the caregiver. This is to be remembered. Then you involve the others also for sharing the load. maybe other relatives, or in between, if somebody chips in, some friends or whoever, it can be very helpful. Financial assistance, maybe from government schemes, hospitals, NGOs, they would be very helpful. Then as a medical person, what you can do is you can counsel the